You are welcome to my channel. Thanks for visiting. Please kindly remember to subscribe and share my presentations. Today, I will be fast and I will limit myself to before transfusion. Before transfusing that blood product, we need to do certain things. I have a separate presentation on blood product transfusion A to Z. If you click on this very link, that will take you there. I've decided to bring this out so that if you are the type that's so much in a hurry, you don't have the time to listen to close to 3 hours of presentation on A to Z on blood products, then you can just listen to this within minutes. But if you have the time to understand everything about blood product transfusion, please click on this very link. The first note I'm going to leave here is this, and I'll start by appreciating all donors worldwide. In some parts of the world, you don't get paid. In other parts, you'll be paid, either for money or for charity. Thank you. Two people with the same hemoglobin level or hematocrit level may not be treated the same way. Why that? We'll know more. One may be transfused while the other won't be transfused. And even those that will be transfused may receive different products. For example, somebody might need packed red blood cells, the other one may need plasma, another one may need platelets. Nowadays, we don't give whole blood, as a form of transfusion anymore. No, whole blood for transfusion, less done nowadays. Some will be transfused even when they have hemoglobin or hematocrit within normal range. Why that? You'll know more. Though we'll talk about many things here, but the common goal will remain the same. We'll go through different products, different patients, different reasons for transfusing each product, but the same goal of sound health. Now, red blood cells. I know many people will expect me to even start with this because many people that will read the heading, blood transfusion, will be thinking about red blood cells. Well, I don't blame you. Blood products, there are many, and red blood cells will just form one out of many. Blood product transfusion. If your blood is taken and put in a tube and it is centrifuged, you are going to see these layers. The lowermost part will be red blood cells. That's about 45%. The uppermost parts will be plasma. That's about 55%. And in between the two will be the bovine coat. It's pretty small, just about 1%, but it's pretty important. Here you're going to find the platelets and the leukocytes. Now, because our goal is to make sure our patients are fine, and that's why we're giving the product either because of anemia, we're giving red blood cells because of bleeding disorders, we're giving platelets because of immune problems, we're giving plasma and the constant, and so on, then we must do it right. So, right blood product to the right person that will need it, we must give it at the right time and at the right place. Still on before transfusion, let us follow the compatibility or the incompatibility test and then be sure we are not mixing things up, because ABO and results is pretty important. So when it comes to O, we regard them as universal donor. But let me leave a note here. They are universal donor of red blood cells. They are not universal donors of plasma. And they can receive only from O when it comes to red blood cells, okay? They can receive plasma from anybody. O negative female, whether children or women of childbearing age, should not receive from O positive donors, though they belong to the same O and O, yet that disparity must be clearly stated. If you are confused why that should be the case, please kindly click on this very link. That will take you to pregnancy and resource factor problems. O positive could be given to all males, either boys or men, and all females that are no longer bearing children, meaning postmenopausal women. They can receive O positive, blood samples, red blood cells. AB is the universal recipient from any group when it comes to red blood cells. That is A, B, AB, or O. But they are universal donor of plasma. So the plasma from AB can be given to anybody. Okay? A can only receive from A and O as far as red blood cells. B can only receive from B and O. Before transfusing, please sit down and make sure the legal aspect is well taken care of. You must sit down the patient or substitute decision maker if the patient can no longer take decision by him or herself, or parents in case of the children. Let there be signed consent after thorough explanation as per the reason or reasons for the transfusion of the product you selected. Then they must know about the type of blood product you have chosen. For example, I'll be transfusing, so child, if it's a parent, talking to a parent, with platelets. And why that? I must explain. Possible side effects must be clearly stated in the language that the relative or the recipient could understand. When there is any trouble along the line, transfusion reactions, that must be reported back to the patient or substitute decision maker or parents promptly. You may seek court order depending on what is obtainable in your jurisdiction. If the parent is not acting in the best interest of the child, or substitute decision maker is not acting in the best interest of the patient. Why do we need this legal aspect? Well, the overall witness, the doctrine, believe they don't want blood transfusion. Well, there's another example of that. If you click on that very link, that will take you to the lengthy presentation on blood product transfusion. You'll find an example that I've stated there. Without consent, in law, it is battery. Though you have intention to help, you're trying to heal, but you can be sued and the patient will win. There are alternatives to blood transfusion, but quote me right, please. I'm not saying when there's massive bleeding or profound anemia, and then we'll be looking for one alternative or whatever. No, it depends. Your physician will make that determination based on what is on ground. That I have given certain pieces of info. When you click on this very link, that will take you there. There are alternatives to blood transfusion, and I will start with iron. Well, I will not go through all this in details anymore because I'm bringing this out for those who don't have time to sit down for a long time. Details could be picked right here. If you click on this link, you understand everything here. But before I move on, iron dextran, intravenous iron dextran, is the worst with possible anaphylaxis, while sucrose is the least with possible anaphylaxis. And it's better you give intravenous iron with erythropoietin in renal failure. Why that? The explanation is right here. Alternatives to blood transfusion could also include erythropoiesis stimulating agents. I will not go through these details because I've done that before. If you want further explanation on that, please click on this very link. Another alternative is giving your own blood to be kept by your surgeon till the time that you need the elective surgery, and then you'll be transfused with it. That is preoperative autologous donation. I'm not going to talk so much about that because it's gaining less recognition nowadays. But if you click on this, I have explained everything about preoperative autologous donation right here. Yeah, click on this link, please. So also cell salvage. In this case, the blood is collected during surgery, it is filtered and washed, then it is reintroduced into the same patient. It's a form of autologous transfusion that could be used intra or post-operatively. Certain medications will be helpful, and you can see the list here. I will not waste your time here. If you want further explanation on that, please click on this very link. It will be good if you can aim at non-liberal, otherwise known as restrictive blood transfusion. In that case, we will use only one unit of packed red blood cells at a time. Then we will have the entire clinical state of the recipient reviewed. If you then need more, you go for more. I'm going to leave a small note here that please don't assume. Assumption about what? Okay, don't assume that the donor is earning enough. In some parts of the world where you don't have the luxury of blood bank, or you're in a rural, remote area where you just need a technician by your side to make up your mind and transfuse to save that life, let us know the hematocrit of the donor. There was a case of someone that's a donor who was ready to give blood, actually gave it, and then at the point of transfusion, then hematocrit level was determined of the donor, and lo and behold, it was lower than the hematocrit of the potential recipient. That blood was not transfused. 1 unit of packed red blood cells is expected to increase hemoglobin by 1 gram per day. 2 hours after transfusion, let's have complete blood count or hematocrit down. The goal is to have 12 gram per DL for women and 13 gram per DL for men. But I'm not stupidly telling you that we have to keep on transfusing till we reach this goal. No. For example, someone is receiving chemotherapy. Maybe you are starting from less than 5 gram per DL or 6 gram per DL. How many units would I want you to transfuse before you reach 13 gram per DL for that man? So make up your mind on what you want to do based on what is available in your jurisdiction, whatever protocol is in your unit. But don't rush, don't give too much at a time. Go for 1 unit of packed red blood cell at a time. Okay, we are heading to lab. It is an emergency situation. Yes, okay, no problem. I'll just go for O blood group, O negative and O positive, because I don't have time to cross match. I will keep the O negative for all women and all females of childbearing age or children that are females. O negative for all of them. O positive for all men, young or old, and all women that are above the childbearing age or who have chosen not to have children again. Okay, but in the case of surrogate motherhood in a woman who is postmenopausal and has received O positive and she's O negative before then that explanation should be made, and that should be part of our history to determine our suitability for the surrogate motherhood status. Then establish compatibility, group and cross-match with resource determination. No, that is out of emergency, right? Then discard after 3 to 4 days and have a complete blood count. Still at the lab, you have to screen for infection and see them. If you want further details, click on that very long one that I've introduced at the beginning. If you have the impression that the donor must have taken a drug, there's no rule or no law saying you cannot have toxicology to be done on the blood of the donor before you transfuse such a blood to another person. So we have gone through all these things. Now we are getting closer to transfuse. Before we do that, we have to check the patient identity, the donor's identity. We should establish that we are using the exact product that we have ordered for. Is it washed or irradiated, or is it whole blood that is no longer used often right now? Is it packed red blood cells? We have to make that determination, right? Then we must cross-check the indications for the transfusion, then determine the dose and the rate. If we are able to do all these things, it will reduce the rate of reactions. Most reactions are from errors. Okay, we need to prepare our own rescue kit in case we run into any trouble because of the transfusion. EpiPen in North America is the same as adrenaline in Europe. Corticosteroids are both more Benadryl, H2 blocker that could be given intravenously, Lasix, tranexamic acid, intravenous immunoglobulin, then acetaminophen or Benadryl. It is controversial in some places because even in advanced countries, some are using this even before transfusion. Well, I've explained further. You can click on this very link to give you further details as per this. Okay, Lasix used before transfusion. In some centers that is obtainable, in some centers it is no. Why do we need to give Lasix sometimes? We need to give Lasix before transfusion depending on the volume we want to transfuse in some patients. Further details is right here. To prevent transfusion overload, 1 unit is okay at a time. You review later on with the clinical state, start the second unit if it's so required, and you may give more than 1 unit depending on what you are dealing with. You may give more than 1 unit if there's massive ongoing bleeding or there's a major surgery with massive blood loss or there's anemic symptoms that is not improving with the 1 unit you've given. Bone marrow failure and the individual is on chemotherapy, you may have to give more than 1 unit. Or there's an existing cardiovascular disease. It depends. So it's not a fixed rule. No. Then set the rate and time. Don't transfuse too cold. Why that? It may lead to arrhythmia, and the patient may die from that. Within 4 hours of taking the blood from the donor or from the blood bank, you must complete your transfusion. You may give 1 unit over 1 hour if there's massive blood loss. So it means you're not going to give it too slowly in that situation. 1 unit over 2 hours if you're dealing with volemic status, and 1 unit over 3 to 4 hours is very common, and that is likely if there is no concern for having fluid retention. Now, we must prevent further transfusion need because we don't want this patient to be coming back all the time, so we must look for and address the cause of the anemia. Okay, so meaning we have to get down to the root. If there is obvious bleeding, occlude that. If there's concealed bleeding, look for it. Get endoscopy done. Folate, vitamin B12, iron deficiency, address it. Is it diet? Do you have to stop boozing alcohol? Do you have to give vitamin B12 exogenously? You understand what I'm saying? Iron supplements, iron 45 foods, intravenous iron, but we cannot give iron in sickle cell disease and thalassemia. You understand that? Renal failure, erythropoietin, you understand? So if you want to know more about sickle cell disease, please click on this link. We don't give iron to sickle cell disease and people with thalassemia. Still on preventing further transfusion need and malabsorption syndromes. Now, and citing medication like chloramphenicol to treat typhoid fever. What is the justification for the transfusion of the red blood cells? This person's anemic with signs and symptoms. Is that yes? Okay, go through the possible signs and symptoms here. Now, still on justification for transfusion, to medical students and nursing students, once you see hemoglobin less than 7 grams per dl or less than 70 gram per liter, the book will tell you transfuse. Some have even put it anything less than 6 grams per dl or less than 60 grams per liter, you must transfuse. But you may not give red blood cells, if you can give iron, and you may not transfuse with packed red blood cells. If the individual is even having this, yet is asymptomatic or not decompensating, instead of giving packed red blood cells, even with this, instead of giving packed red blood cells, just give your intravenous iron. If this person is young and he or she has no symptoms, even with this level, you may not give packed red blood cells, you just give your intravenous iron. Remember, dextran will give you the worst anaphylaxis, sucrose will give you the least. I'm not an agent selling dextran or an agent against sucrose, no, just telling you the truth. In chronic iron deficiency anemia, you may not transfuse, you may just give iron. But there's no iron exogenously that must be given to sickle cell disease patients or people with thalassemia. And lastly, if someone is to undergo operation, under certain situations, you have to prepare for perioperative transfusion. One, if that operation will be a major surgery or is going to be a vascular surgery, you should envisage a massive blood loss. In that case, just tell blood bank, get the number of units of blood for us. You may not use what you've ordered for, but just in case, be ready. If there's iron deficiency anemia and the individual is to undergo operation, please prepare your mind for perioperative transfusion. If you want to know more, please kindly click on this very link. With that, I've come to the end of this short presentation. I've decided to cut this out of the long presentation, if in case all you need or all you want to know is the process or the steps to be taken before blood transfusion, then you have it. But if you have the time for about 2 hours, 55 minutes, then you're going to get these and many more when you click on this very link. I appreciate it. Please remember to subscribe. Please remember to share my presentations with your friends. I appreciate it.